The broadcast is now starting. All attendees are in listen-only mode.
Hi, good morning, everyone. Thank you so much for joining the Georgia Clinical Quality Measure System, Georgia CQMS webinar. My name is Christy Washington, and I'm a Pop Health Research Data Analyst here at DCH, and I will be your moderator for this webinar. This is part 3 in the Take 5, How eCQMs Improve Patient Care and Outcomes webinar. Jeff Jacobs with DXC Technology will present an overview of the program, followed by a system presentation by Teresa Harris from DXC. We will deep dive into 2 CQMs for monitoring chronic conditions with Chris Huckabee, and a clinical perspective will be given by Dr. Dan Roach. This presentation will show the system capabilities and functionalities, including how to enter clinical measures data and generating provider performance comparison reports. I'll just take a moment to go over a few housekeeping rules. Please hold all questions until the question and answer session. At that time, please raise your hand and you'll be unmuted to ask your question, or you may type your question in the question pane and we will read your question aloud. This webinar is also being recorded. The webinar will be, the presentation, and the recording will be available on the DCH website. This presentation is also available in the handout section. If you're unable to download it, please send an email to hit.info@dch.ga.gov, and we'll be happy to send you a copy. Again, that's hit.info@dch.ga.gov. All right, and at this time, one more thing. There is a brief survey at the end of the webinar, so please take a moment to complete that once the webinar is over. And at this time, I will turn the webinar over to Jeff. Thank you.
Okay, good morning. This is Jeff Jacobs. I'm the account executive with DXC. We serve as the fiscal agent and are participants on the GA-CQMS project. Appreciate your time this morning. We're going to share a lot with you that we hope is helpful and of interest to your organization. We'll start off with the mission of the department. The mission of the department is to provide access to affordable quality health care for Georgians through effective planning, purchasing, and oversight. The purpose, of course, is to shape the future of a healthy Georgia by improving access and ensuring quality to strengthen the communities that we serve. Our agenda, as Christy mentioned, is essentially to provide an overview, some benefits, some details on some specific quality measures, and then a clinical perspective from one of our advisory board members. So today's webinar is really to share with you about our Georgia Clinical Quality Measure System project, or Georgia GA-CQMS. Very similar to some requirements and some processes that you see on the Medicare side of the house, CMS side of the house. Medicaid is initiating a project to implement, which is done, and operationalize an effective way to accept CQMs to support program initiatives. And so we hope to do that by assessing trends against various benchmarks. Those could be disease categories, provider geographies, or comparison of provider types. And the whole approach is a phased approach where we hope to gain insight and lessons learned that will then turn into influencing us when we roll out to a larger community. As many of you may know and experience in your practices today, CMS and the industry is really moving to more of an outcome-based assessment for the services being rendered to assure that the services are meeting the need and accomplishing the results desired in a cost-effective way and in a way that provides a great experience for members and sort of gets the results that we're all seeking. One of the things that we want to do as we go through the presentation is take a second and ask you some questions. We hope to gain insight from you. These are really short questions that just require a quick yes or no. So our first question, is your practice currently looking for an effective way to capture clinical quality measures? Is your practice currently looking for an effective way to capture clinical quality measurements? And so there's a poll feature on the WebEx there where you can indicate yes or no. We'll give you just a second for that. Again, is your practice currently looking for an effective way to capture clinical quality measurements? So it looks like yes, it looks like we've had some input from some of our participants. We will have a couple more poll questions, so thanks for your input on that. It's always helpful for us to get insight from you as well. Okay, so let's talk about some of the project benefits, right? So ultimately, we're, you know, maybe you've heard the phrase, you manage what you measure, right? So we ultimately hope to gain project benefits where we improve health outcomes for Medicaid members, very much aligned with CMS direction through the effective use and comparison of provider-generated data. Ultimately, we can get sort of the services that are being rendered through some claims assessment. We can see diagnosis information on claims, but we don't get to see the kind of data-rich information that comes out of EHR systems. So we need to supplement our current environment with systems and functionality like what we're providing in the GA eCQMs project. To just get ahead of ourselves a little bit, this is a free tool that we make available to providers. It is something where we ask for quarterly collection of these CQM records, and we hope to do that in a really efficient way, right? We know that you're busy, that you have multiple jobs, day jobs, night jobs, weekend jobs, as it comes to just maintaining your practice activities. And so we're really focused on making participation in the project a really efficient, time-sensitive activity, and we'll share more about that. So ultimately, again, creating a platform using consistent, rules-driven evaluation of the effectiveness of and ultimately providing value-based outcomes, improving health outcomes, informing providers on performance, and informing the state on performance, right? All right, so let's come back to the polling question. The next polling question, again, we'll do this very briefly, is would comparing provider data to state average data benefit your practice? Would it be of benefit to have some comparison against how individual providers' data compares to state average data? And that's one of the tools. Obviously, we sort of set that up a little bit, and that's one of the great resources that we have as part of this application. We collect thousands of clinical quality measures through the EHR incentive program as part of the meaningful use reporting. And so it ultimately provides us a resource that we can use as a state average to compare against some of the individual provider data for those participating on the project. So very specifically, the project provides training to leverage the certified EHR system capabilities. We can accept the data. You know, EHR systems, many of our EHR systems can output CQM data in an electronic transaction file referred to as a QRDA Cat3. You know, the equivalent on the claim side would be like an 837 X12 transaction, 5010, you know, sort of claims transaction. But on the EHR side, it's an HL7 derivative, QRDA Cat3 file, or it can be manually entered. This data that we're collecting is really PHI friendly because it's aggregate level, so we're not looking to get any member-specific data. So the data that we collect is really at the aggregate level. So you'll see it's like a numerator, a denominator, if there are any exceptions or exclusions applicable, and that's it, right, per measure. So as few as 4 data points per measure. We display the data after it's entered through a dashboard function. Teresa's going to show that in just a second. And one of the things that we implemented as a result of some of our initial activities, and that's really the whole goal of this project, we're hoping to have some folks participate with us on a small scale. We're not looking to get hundreds of providers participating at this point in the project. We're looking to have a small number of project participants that can give us feedback, that can talk to us about their experience, again, being sensitive to everybody's schedule. And one of the challenges that we faced early on was even the manual entry. If you have a practice with a high number of participants, can take some time. Well, we'll do the data entry for you if you'd like. If you'd like to prepare that data, maybe your EHR system is not quite ready to output the data in a QRDA format, no problem. If you can just output it as a text file or as an Excel file, Word document, PDF, we're flexible. We'll take that data and we'll enter it directly for you. It will generate an email for you to confirm that the data looks as you expected it, and then you'll gain the benefits of the dashboard functionality. Next slide talks about the fact that we have a clinical advisory board. So that's one of the great benefits, and you'll hear from one of our clinical advisory board members, Dr. Dan Roach, at the tail end of our presentation. And really their goal and their role is to provide the clinical input, right, to help advise on the measures that we're selecting, to take input from other project stakeholders and make recommendations on the use of the data, reports coming out of the data, and just to support in a collaborative way with the department on how to shape things moving forward. We get a lot of benefit from the clinical advisory board, and so we appreciate their participation. It includes folks like Dr. Dominic Mack from Morehouse, and he's been a great benefit. We also have some participants from Health Tech Solutions who also are a key participant in the project, and you'll hear from Chris Huckabee, I believe, later, and she also provides input at our advisory board forums. Okay, polling question number, I think this is number 3 of 4 total. This question, would you utilize trend analysis or reporting to monitor population health? And in your case, of course, it would be the population that you serve. Would that be helpful to have that sort of trend analysis or reporting to monitor how your population's performance is occurring against the measures? And so we'll give a second for folks to vote. And there we go. Thank you very much. We'll give one more second there. If anybody else wants to provide input, we appreciate your input on these questions. Okay, so it looks like, yes, that would be helpful to have that, and we'll, again, that's sort of teeing up some of the information that Teresa will share here momentarily. So right now we have 7 participating provider organizations. We've got over 50 individual providers loaded into the system. We have currently 7 CQMs that we're measuring. I'm going to share with you what those are in just a second. We're removing 1, but then we're adding 7 more. So we'll end up with a total count of about 13 CQMs. Our hope is to load that data quarterly. Again, we want that process to be efficient so that it is limited time required for our participants in the project. So let's show you the CQMs that we're collecting. These really were identified in part to provide some comparison against some of the HEDIS reporting that's provided. These are some focus areas based on Georgia initiatives based on input from the Clinical Advisory Board and key stakeholders. And so you can see here, it goes sort of across the board. There's some behavioral depression screening, there's BMI. Some of these things are very standard in some of the typical office visits that may occur, and then some of them are unique with breast cancer screening, chlamydia screening for women, controlling high blood pressure, and then our new ones, our new CQMs. Let me see, did I get my count right? 2, 4, 6, 7. I did get my count right, so that's a check mark for me. So I get to come back and do a presentation in the future. So these are some additional. So some of our input from our project participants was maybe a little bit more on the pediatric side of the house. We've heard the same on geriatric medicine. So we'll have a balance. Over time, we'll continue to grow this list, but we're looking forward to these measures being added. And again, Chris Huckabee is going to talk in just a minute about some of the measures in depth to give you a sense of the kind of things that we're looking at in the measures that we're currently reporting. Okay, our last polling question is related to whether your practice has spoken to your EHR vendor about QRDA files for clinical quality measurement. So this is pretty specific to any discussions that you might have had with your EHR vendor about the ability to report using that QRDA file information. And we do find this one has a tendency to not have as high a yes response as some folks have had experience with the reporting of these measures through the QRDA, and some have not. So thank you again for your input there. We appreciate your participation in the polling. So let's step back and see a little bit of the system and a little bit about how this functionality works. Teresa Harris is our project representative from DXC, and she's going to walk us through some of the basics. Teresa?
Thank you. Thank you, Jeff. Good morning. Good morning. Again, I'm Teresa Harris. I'm the eCQM project representative. What you see currently on display now is the actual login screen for the Georgia Clinical Quality Measure System. So once you are registered as a participant provider, you'll be given access to the system, and you'll log in with using an NPI ID and then as well as a password. So this is an easy functional system to be able to log in and start tracking your CQM data. Once you log in, the next screen you will be presented with is what we call the dashboard. And so the dashboard, we found that a lot of providers enjoy seeing the dashboard once they log in, because right away you see your stats, you see the CQM measures, you see the state average. And so right in front of you, you'll be able to look at how well your practice is looking to do for clinical quality measures and how you're measuring against the state average or with the state average. So one of the easy functions from the dashboard is, let's say you want to look at one of the clinical quality measures in a more detail or more of a trending perspective. So what you can do is you can just click on one of the CQM measures. Let's say if you click on CQM 153, which is chlamydia screening. And once you click on that, you'll be presented with a trend graph. The trend graph will show you on a quarterly reporting level, and you'll be able to see how well your measure for chlamydia screening, how well it trends for quarter 1 through 4 for the year that you selected. Also, with the GA-CQMS system, we have another area where you can view your stratum information. And the reason why I'm saying stratum is because some of the measures that CMS has verified to be reported for electronic clinical quality measures requires reporting stratum information. So here you can see the report will appear for stratum information for chlamydia and it would be for age group 16 through 20 as well as 21 through 24. So the Georgia Clinical Quality System on different measures based on the CMS requirements for those measures will allow you to drill down a little deeper into the stats. Okay. So next question, how do I get the information? How do I get my CQM information into the Georgia Clinical Quality Measure System? If you can see to the left, we have a menu option that's called Add View CQMS. Once you click that option, you'll be presented with an option to enter your data manually or either through QRDA3 load up a file. So we do have a couple of simple options to be able to allow you to be able to enter your data for CQM. And then once you enter that information, you'll be able to view it at, like I said, on the dashboard whenever you log in. All right, so once you choose, let's say we choose to enter our CQM data in a manual entry. Once you choose the manual entry, you'll be presented with the CQM ID, and there you would enter your numerator, denominator, exclusion, exception. And each one of these may differ based on the requirements per CMS. And once you enter that data, your CQM data, you can hit save or next, and it will automatically save the information for you. At the end of entering your CQM data, you'll be presented with a detail screen, a summary screen, that allow you to just visually view your CQM data for your CQMs that you have entered. The example that shows here displays CMS2 with the numerator 12, 25, 2 is exclusion, and 1 is exception. So this is a great screen to use just to view. You can expand the data, you can, excuse me, collapse the data. So this is a great tool that's often used by our providers to review their data. So once again, thank you for participating in the GACQMS webinar today, and we look forward to getting you registered, giving you a login ID, and helping you get your data entered into the Georgia CQMS.
Okay, so let's do a deep dive. I think we've got Chris Huckabee on the line, and so let's talk about a couple of the measures in a little bit more detail. Chris?
Thank you, Jeff. Hello, everyone. This is Chris Huckabee, and as Christy and Jeff have mentioned earlier, we're going to take a deeper look into a couple of chronic condition measures. Next slide. So the first measure that we want to discuss is CMS 122, diabetes hemoglobin A1C in poor control greater than 9%. So for the measure description, is the percentage of patients 18 to 75 years of age with diabetes who had a hemoglobin A1C greater than 9% during the measurement period. The denominator is focusing in on those patients 18 to 75 years of age with diabetes who had an office visit during the measurement period, and specifically looking for, in the numerator, the patients whose most recent hemoglobin A1C level was performed during the measurement period and the result is greater than 9%. To break down the numerator criteria just a little bit further, the patient encounter is numerator compliant if the most recent hemoglobin A1C is resulted and it's greater than 9%, or if the A1C test was performed but it was not resulted, or if the diabetic patient has not had an A1C test performed during the measurement period. So this can be a little confusing, but what this measure is actually looking for is for a low number in that numerator spot, as this demonstrates better quality of care. So when caring for a diabetic patient, especially those with an A1C greater than 9%, as providers, we should be ordering this lab test every 90 days and documenting the results of that test. Next slide. So who is excluded from this measure? Those patients who are receiving hospice care and that care overlaps the measurement period. There are no denominator exceptions for this measure. Only those patients with type 1 or type 2 diabetes diagnosis should be included in the denominator. If the patient has diabetes secondary to another condition, those should not be included in the denominator. According to the CDC Health Report 2017, diabetes is the 7th leading cause of death in the United States, and that those with diabetes are at risk for serious health complications such as vision loss, heart disease, stroke, kidney failure, and even amputation of toes, feet, or legs, and sometimes hands and arms. Reducing that A1C blood level by 1%, so going from 9 to 8 or 8 to 7, this will reduce the risk of microvascular complications by as much as 40%. So next slide. So how will having aggregate data in the Georgia CQMS help me to improve care to my patients? So as Teresa demonstrated, as a provider, when I log into the Georgia CQMS, the landing page is the dashboard that you see. I can see fairly quickly that I'm at 60% for this measure as compared to the state average of 48%. In other words, I have identified more of my type 1 and type 2 diabetic patients whose A1C is either greater than 9%, I ordered the test but the results were not documented in the record, or the A1C was not done. So the first thing that I need to ask myself is, am I happy with that number? I need to remember that for this measure, lower percentage means better quality care. Would I like to lower that percentage? So this should prompt me to be thinking of ways to improve the health and care to this specific patient population. Having this data readily available will help me to improve the care to my patients because I can see where there may be a gap in care. On the next slide, I can also see how well I've been doing on this measure over a course of a year. So in this trend line graph that shows the trend over 4 quarters of 2017 for this measure, I can see that whatever actions that I took after identifying gaps in quarter 2 in the patient care, it has been effective as shown on this trend graph by quarter 4. I'm below the state average in quarter 4, meaning that I have less patients in my diabetic population that meet numerator criteria than I did in quarter 2. Next slide. So the next chronic condition measure is CMS 165, controlling high blood pressure. For this measure description is the percentage of patients 18 to 85 years of age who had a diagnosis of hypertension and whose blood pressure was adequately controlled less than 140/90 during the measurement period. For our denominator, it's the patients 18 to 85 years of age who had a diagnosis of essential hypertension within the first 6 months of the measurement period or any time prior to the measurement period. Numerator specific is those patients whose blood pressure at the most recent visit is adequately controlled. The systolic pressure is less than 140, the diastolic blood pressure is less than 90 during the measurement period. Next slide. For our denominator exclusion, this will include those patients with evidence of end-stage renal disease, dialysis, or renal transplant before or during the measurement period. The patients who are pregnant during the measurement period, and we'll also exclude the patients who's on hospice care and that care overlaps the measurement period. Again, there are no exceptions, denominator exceptions for this measure. Only the blood pressure performed by a clinician in the provider's office are acceptable for numerator compliance. So what that means is The patient home readings, which a lot of the patients do bring their home readings in, are not acceptable for the numerator criterion. If there's no blood pressure recorded during the measurement period, the patient's blood pressure is assumed to not be controlled. And then also, if you take multiple blood pressure readings on the same day, you would use the lowest systolic and diastolic reading of the day as the most recent. Hypertension is very common and affects 1 in 3 adults in the United States. High blood pressure increases the risk of heart disease and stroke, as does diabetes. Half of those affected are in good control. Better control of blood pressure can significantly reduce the probability of an undesirable and costly outcome. Antihypertensive therapy has been associated with reduction in stroke incidence by 35 to 40%, a reduction in heart attack by 20 to 25%, and a reduction in heart failure by greater than 50%. These are statistics based on clinical trials. The relationship between controlling hypertension and long-term clinical outcomes is very well documented. Next slide. So going back to that question of how we're having this aggregate data in the Georgia CQMS help me to improve the care to my patients. Again, back to the dashboard, which is the first thing when I log in that I see. I can see fairly quickly that I'm doing about the same as a state average for my hypertensive patients. The second thing that this lets me know is that I'm at 60%. What does this number tell me? Am I happy with that number, or what else can I do for them? What about that 40% that's still out of range? I know that 1 in 3 adults in the United States have hypertension and are at risk for heart-related issues. So I should be thinking about ways to help that 40% of my patients either become more compliant with medication, because some of the responsibility does land with the patient regarding their care. And maybe help them make some of those lifestyle changes that can help lower blood pressure. Again, on the next slide, I can see how I have measured up for 2017. I saw back in Q1 that I had some work to do with helping my hypertensive patients get into a healthy range of blood pressure. I can use this report to see how well my interventions with identifying that gap in care with the patient population have improved the health of my patients. I began the year at 30%, and by Q4, 74% of my patients had a controlled blood pressure. So are there any questions about either of these measures?
So from a, go ahead.
Nope. I was just going to turn it back over to you, Jeff.
Okay, and I was just going to say, folks can use the question or the chat feature if you have any questions that you want to ask as we work through or wrap up. Thank you very much, Chris. Lots of good information there and good information to share. So next up, I believe we have Dr. Dan Roach, who again is a member of our Clinical Advisory Board, and Dr. Roach, will hand it off to you.
Okay, thank you. And can you go ahead and advance to the, there you go, that's perfect. So I'll just talk around this slide and I'll be very brief. But basically, you know, what we see is opportunities here is to improve patient care, but also to accomplish the CMS quality strategy goals, and then the benefit of being able to collect and analyze this data and how that can benefit. So just to start with the opportunities, as Chris really went through and you saw very clearly on the screen, it helps you identify these gaps in performance. You know, a lot of times the problem is not being able to do the right thing, but it's knowing who to do it to. You know, you don't, if someone doesn't show up in the clinic, then you really may not even remember that that person is on your panel if they haven't been there in, you know, a couple of years. So having this information allows you to identify people and to see the gaps in performance and be able to actually manage their care more effectively. So it's tools for you to be able to make a real difference in the quality. You know, and then as has been mentioned many times, you know, as we move into this value-based reimbursement model, these kinds of opportunities, you know, help with the financial aspects as well, and to not only save money but to maximize revenue into your clinic. So then to talk about the CMS quality strategy goals, we've all heard of the triple aim, you know, better care, lower cost, better patient care experience. But CMS, the actual mission statement says this, and I'll just read it. It says, to optimize health outcomes by leading clinical quality improvement and health system transformation. And there are 6 components to these goals, or to this goal. And I'll just go through them very briefly. They're very self-explanatory, but the first one is to make care safer by reducing harm. And oftentimes it's not what you do that causes the harm, but it's what you don't do. And usually when you don't do it, it's because you don't know you need to do it. And because, again, like I said before, people just don't show up, and it's hard to know where to make a difference. And so this is empowering you, giving you information so that you can actually locate people and patients that need to be part of this quality program. The second is to strengthen person and family engagement as partners in their care. Again, as people become more involved and as patients start to think of themselves more as consumers of healthcare, having that family around them can help with compliance and all kinds of things, and so that it's an extra set of hands to help in the care of the patient. The third is to promote effective communication, coordination of care. Again, just having the information available so that you know other things that are being done, and be able to communicate with other providers that are managing the care of the patients. Promote effective prevention and treatment of chronic disease. That's very self-explanatory there, and as you saw through the tool, that information is available. Work with communities to promote best practices of healthy living. Again, just the community of care around a person, not just in the healthcare system, but in the community at large. And then to make care affordable. And again, that's just the efficiencies of care, of doing the right thing at the right time to avoid the bad outcomes. So it's hard to predict or to put a number on savings. If the things that can happen don't happen, it's hard to put a number on that. But we all know that it's a lot less expensive to take care of somebody with diabetes before they have an amputation than after. And so those are the 6 parts of the CMS quality strategy. And then finally, I'll just talk about how data collection and analysis, they really do lie at the heart of quality improvement. And we believe very strongly in providing you the tools to see where you are. If you're being measured, if you're going to be held accountable, then I personally believe you should have the information as well, so that you can actually see where you are and where the gaps are, and how you can change the practice patterns or change communication methods or whatever needs to happen to actually affect a change on a particular quality measure. And the data and the information that's provided can allow you to do that. And I think that's all I wanted to talk about. Just wanted to be brief today.
Thank you, Dr. Roach. Again, great information. Appreciate your input. And so that really brings us to the end. We wanted to share with you about the application, about the functionality, about the great depth of detail related to the measures and the quality of information that's collected through the measures, and then how we're really aligned and focused on some of the benefits, as Dr. Roach outlined, that we expect to gain. So let me pause here. Any questions that we can respond to? And I think I think you can send a question through the chat or through the questions feature, or I think we're going to open up the line so that you can speak. And so I will caution, sometimes when we open up the line, if folks don't have their phone muted, we'll we'll hear folks, we'll get to hear what people are planning to have for lunch, maybe. If anybody's already thinking about lunch, I know I am. So we'll get focused here. So we'll open it up for any questions. Again, we're going to unmute real quick, and we'll mute back if we have a lot of background.
I wanted to ask the other providers, how would it benefit you to see your clinical quality measure data in comparison to others within your group? If you would, please raise your hand and or speak I want to know from the providers, how would it benefit to compare your data, your clinical quality measure, to other providers in your group?
And folks can unmute themselves if they want to provide some feedback. Okay.
I didn't know if somebody was trying to talk. I did hear something in the background.
And we're trying to unmute where folks may have interest in providing feedback.
Would there be an interest for you to compare specialty to specialty? Like, and just asking as an example, you know, dentist to dentist, or gynecology to gynecology?
Okay, again, I want to make sure that we make available an opportunity to ask any questions or provide any feedback. However, if we go to our last slide here, I do want to share our contact information. Again, our hope in providing this information is that you might be interested in learning more. We've given you a lot of the information on the project. Frankly, if you are interested in participating, it doesn't take that much more time to participate. Really, at this point, it would be a matter of, we have a very simple participation document. It's a one-pager. It couldn't be simpler, and just really confirms with you that we're going to hold this information in a confidential website as we've reported. There's no PHI involved. We're going to keep your participation to a brief level so that we don't take much of your time, respecting that you have a lot going on at a practice. And but we want you to benefit from the value of this information that's available, right? And we think there's a real value there. So if you'd like to participate, if you'd like to learn more, here's the email address. That is gacqms@dxc.com, or you can call us at 866-211-0949. And then finally, we have a couple of more webinars coming up. They're very similar to this webinar. And so really, the best way to move forward, if you would express interest to us directly, we'll follow up with you individually and take it from there. I think that brings us to the end. We really appreciate your time today, and hope that you will consider participating with us. Thanks, everyone.